Hello, this is Sanjil Lee. I'm a clinical assistant professor in the Department of Emergency Medicine at the University of Iowa Carver College of Medicine. Today we will talk about measuring cognitive vital signs to identify delirium. Here is my disclosure. I am currently supported by a Health Resources and Services Administration Award for our project, Iowa Geriatrics Workforce Enhancement Program. Our goal is to improve the care of older adults. We have three learning objectives. The first objective is to understand delirium. The second objective is to understand the list of delirium assessment tools that are available in the acute care setting. And the third objective is to understand the concept of what is called the Confusion Assessment Method, or CAM, along with the modified CAM called the B-CAM, and how it is applied in the emergency department. So what does delirium look like? Let me give you a typical scenario. You are taking care of a 78-year-old female patient who fell and was not able to get up. The patient called the ambulance and came to the emergency department. You are seeing the patient in her room. The patient has obvious shortening of the lower left extremity and is quite painful with range of motion, and you are concerned about hip fracture. Oddly, the patient is unable to answer any of your questions. The patient is trying to pull out her IV and seems somewhat agitated. You talk to her caregiver, who arrives later, and confirm that the patient is usually able to answer questions and converse. Based on this scenario, you get the idea that the patient has a left hip fracture. But we do not know what to do with her confusion or altered mental status. This is what delirium looks like. What is delirium? Delirium is a global brain dysfunction that is common, serious, and fatal. In the emergency department, we see about 8% to 16% of delirium. It has several features. First, the patient's mental status change is new. Second, the patient with delirium usually has impaired attention. Third, the patient may have an altered level of consciousness during your assessment. Fourth, the patient may demonstrate disorganized thinking. It is important to note that fluctuating mental status over time is an important feature of delirium, and is frequently the reason that delirium is missed. Clinicians can miss up to 80% of delirium if they use only the clinical gestalt, so there is an opportunity to improve identification by introducing routine delirium screening. The potential benefits of routine screening would be an accurate diagnosis of delirium and early identification of a high-risk patient population, which would be someone needing a physical or chemical restraint, one-to-one nursing care, and the mobilization of the behavioral health emergency team. Lastly, the identification of delirium can lead to increased reimbursement. So what is the best way to screen for delirium in the emergency department? What type of instrument can we use to identify delirium? There are similar instruments that are designed to measure mental status. Let me give you one example. The Glasgow Coma Scale, or GCS, is designed to measure mental status, but this instrument was designed to identify severe head trauma. Although this is a great tool to use during trauma, it is not the best fit to identify delirium. The gold standard to detect delirium is a psychiatrist interview. The DSM-5 is a diagnostic reference for psychiatry that includes criteria for delirium. Psychiatrists are experts in evaluating these criteria, but they are not always available in an acute care setting. Non-psychiatrists need to be able to evaluate delirium since it is common, and many are less comfortable assessing these criteria through observation alone. Do we have anything else? How about the Confusion Assessment Method, or CAM? This instrument was developed by Sharon Inouye back in the 90s to improve the diagnosis of delirium by non-psychiatrists. This instrument is one of the most widely used delirium identification tools. The CAM algorithm has 4 features. It requires feature 1, which is a fluctuating mental state over time, and feature 2, which is inattention. For a diagnosis of delirium, you need feature 1 and feature 2, along with either feature 3, which is an altered level of consciousness at the bedside, or feature 4, which is disorganized thinking. Providers are required to use cognitive assessments to identify delirium with the CAM. Another instrument that is worth mentioning is the CAM ICU. This instrument was developed based on a CAM algorithm, but is designed to detect delirium in the intensive care unit setting. The CAM ICU can be used for a nonverbal patient, such as one who is intubated. It has high sensitivity, specificity, and inter-observer agreement. However, the validation study in the emergency department showed modest sensitivity. Do we have any tools to detect cognitive impairment and delirium? The answer is yes, there is one. It is called the 4AT. The 4AT uses a scoring system to identify possible delirium or cognitive impairment. This consists of alertness, orientation, attention, and fluctuating mental status. A score above or equal to 4 means that the patient may have possible delirium or cognitive impairment. A score of 1 to 3 indicates possible cognitive impairment, and a score of less than 1 means that the patient does not have delirium or cognitive impairment. The 4AT has high sensitivity, but the specificity is relatively modest. The benefit in this case is that the 4AT is really easy to use, and it has been validated in the emergency department setting. Let's talk about the confusion assessment method. This is a great tool that was developed based on the diagnostic criteria for delirium. It requires at least 3 features to diagnose delirium. Feature 1. The patient needs to have an acute onset of a mental status change. This could be identified by the patient's history or collateral information from a caregiver. Feature 2 is about inattention. We can use the months of the year backward question to test the patient's attention. To diagnose delirium, you have to identify both Feature 1 and Feature 2. Then we can move on to Feature 3 and Feature 4. Feature 3 is about assessing the patient's level of consciousness. This is something you can identify based on your bedside assessment. We will talk about the specific tool to use. Feature 4 is about disorganized thinking. This is assessed by asking a couple of questions to test the patient's knowledge and the response to a command. You need both Feature 1 and Feature 2 and either Feature 3 or Feature 4 for a diagnosis of delirium. In other words, if the patient can demonstrate attention, you can rule out delirium. Now let's talk about the screening tools that we are proposing in our emergency department. We will have a 2-step approach. Step 1 will be a delirium triage screen performed by the nursing staff, and Step 2 will be confirmation of delirium by a physician using the Brief Confusion Assessment Method, or BCAM. The delirium triage screen, or DTS, will assess altered level of consciousness by using the Richmond Agitation Sedation Scale. Then the nursing staff will test attention by asking the patient to spell lunch backward. If the DTS is positive, then clinicians will be asked to do the BCAM. If the DTS is negative, then the screening process stops. We are going to focus on how to administer the BCAM. Now let's go over each feature for a BCAM. For Feature 1, we can use a single question in delirium, or SCID. The question that you can ask is, do you feel that patient's name has been more confused lately? This is a very simple question, but it has a sensitivity of 80%, specificity of 71%, and a moderate kappa for predicting delirium. Keep in mind that Feature 1 is sometimes difficult to assess when there is no collateral information. Next, we will talk about Feature 2 of the BCAM. We're going to use the question called Months of the Year Backward, or MOYB. You will ask the patient, can you name the months of the year backward from December? Healthy patients should be able to call from December back to June without a mistake. It is important to note that the patient cannot have delirium if they do not have inattention. If the patient can name the months of the year backward, then they are not going to meet the diagnostic criteria for delirium, so you can stop the assessment at that point. Now let's talk about Feature 3. This is assessed by using the Richmond Agitation Sedation Scale, or RASS. The scale goes from -5 to +4. A healthy individual who is awake and able to answer the question appropriately will get a scale of 0. Someone who is drowsy would have a scale of -1. Someone who is receiving moderate sedation would be at a -3. Someone who is in a coma would have a scale of -5. On the other hand, if the patient is restless or anxious, they would get a scale of +1. If they are agitated, the scale is positive 2, and someone who is combative and needs to be restrained would have a scale of positive 4. Another important tip here is that someone who is drowsy or comatose may not be able to answer the question to assess attention. Since the patient is confused, then the level of consciousness is abnormal, so you can diagnose delirium based on the RASS and the inability to assess feature 2. You do not have to administer the months of the year backward test for someone who is comatose or combative. The patient has delirium. Feature 4 is to test disorganized thinking. You will ask a series of questions. Will a stone float on the water? Are there fish in the sea? Does 1 pound weigh more than 2 pounds? And can you use a hammer to pound a nail? You will also provide a command such as, hold up this many fingers. Now do the same thing with the other hand. If you notice any error for these questions, you can count that as a positive feature 4. Let's talk about the screening tools one more time. The initial process starts with the DTS, so the nursing staff will assess altered level of consciousness and then assess attention. If the DTS is positive, then proceed to the BCAM because the DTS has a sensitivity of 98%, but specificity of about 50%, so the positive DTS will have to be confirmed by the BCAM, which has a high specificity. Since the sensitivity of the DTS is so high, a negative DTS will rule out delirium without further tests. If the DTS is positive, the clinicians then perform the BCAM. The BCAM has moderate sensitivity but very high specificity. It is relatively easy to perform and it takes about 2 minutes or less. This will help to confirm the diagnosis of delirium. This concludes the presentation on cognitive vital signs to identify delirium in acute care settings. I hope that you understand the definition of delirium, several instruments to identify delirium, and how we use a delirium screening tool, the DTS, and the BCAM. After this presentation, there will be a post-test and a practice video that I recommend you watch. Thank you.